Hello everybody, this is Shana Sirney. I'm going to be talking today about using a sensory motor approach for feeding skill acquisition in our children who have Down syndrome. As many of you know, when we start to introduce foods, or even as early as bottling, our kids that have Down syndrome might demonstrate some difficulty in transitioning from the breast to the bottle, from transitioning from the bottle to food, or even just starting very early in their life, having difficulty latching onto the nipple. Today we're going to talk a little bit about both the motor aspects, such as hypotonia and weakness in the muscles, as well as the sensory processing aspects, and how these factors can contribute to the difficulty of eating. So specifically, our objectives for today are to describe what we know about children with Down syndrome in relation to oral motor control and sensory processing. We're going to identify medical, developmental, and sensory issues that contribute to feeding, eating, and swallowing problems. And we're also going to look at the literature to help guide us in evidence-based interventions to help promote participation in eating activities. So like I said, my name is Shana Sirney. I am an occupational therapist here in South Dakota in the United States. I work specifically with the pediatric population. I teach full-time at the university. In addition to teaching, I have one full day, one full caseload. I work in the school district, and I also work in outpatient pediatric practice. I work in early intervention, which means I get to work with the very young children aged birth to 3. But as I said, I also do the school district and outpatient services, seeing children all the way up to age 18. I really believe in using a team approach, which is what you will see today, working closely with the families, the teachers, the other team members such as the speech therapists, physical therapists, psychologists, and physicians, really lets us take a systems approach and supporting these children to develop optimally. So what do we know about oral motor control and sensory processing in children with Down syndrome? There are some things that we know. First, you're going to hear about tone from a lot of us today. Muscle tone is the amount of tension that a muscle holds when it's at rest and the ability of that muscle to contract on command. So when a child has low tone, they might have a slightly soft or floppy feel to their muscles. They also have difficulty with graded control of activation of that muscle. Now this we'll see in both our gross motor movements or areas of the body, so the shoulders, the trunk, the pelvis. We'll see it in the fine motor areas, in the hands. They might have difficulty grasping, but also in the mouth, the muscles of the cheeks, the tongue, and the lips. We also know that children with low tone or children with Down syndrome likely will have either a large tongue or a smaller oral cavity. We're going to talk about the implications of this biological aspect in just a moment. The next 2 points really go closely together. Children that have Down syndrome have been found to have muscle weakness and low energy when we look at their sensory processing profiles. When a child has muscle weakness and low energy, it's more difficult for them to react to the stimuli that's being presented. This makes it difficult for motor planning. Motor planning is the way in which our body reacts to the stimuli around us. This again is not only gross motor movements when we think about running, jumping, crawling, but this again is motor planning orally, stabilizing the food within our mouth, moving it from side to side with our tongue, keeping it within the mouth until it's able to move to the back of the mouth for a swallow. Again, when we have that lower awareness of sensory input, it's difficulty to react to it. And so our kiddos have difficulty with motor planning. We also know, like I just said, that children with Down syndrome have difficulty processing sensory information. Specifically, investigators have identified delays and differences in cognitive, language, motor, and sensory development in children with Down syndrome. Again, this is delayed. They are still reaching those milestones. It's just a little bit later than their peers. The highest rate, or the most probable difference that they'll have in sensory processing ability, is that low energy and weakness. The under-responsiveness, which means they're not as aware of the stimuli around them, meaning that it takes a higher caliber of that stimuli to get them to react. And they also have difficulty with auditory filtering. This is the ability to be able to tune out certain noises so that they can focus on the important ones. So now we need to think, well, how does all of this affect their ability to eat? So we're going to integrate what we know about oral motor control and what we know about sensory processing in children with Down syndrome and apply it to the task of eating. So like I said, first we know that children with Down syndrome have low tone. This results in decreased jaw stability, cheek tension, lip closure, and tongue movement. Many times children with low tone will actually hold their mouths open. When they do this, as you can try, when you have your mouth open, swallowing is difficult. The swallowing may be strained. They may lose some liquid out to the outside of their mouth. These manifestations can often lead to choking, tongue protrusion, both during swallowing and when not eating, because the lips are not closed to hold that tongue in. We may have a loss of food, and the children may have a difficult time progressing to mixed textures and manipulating those mixed textures in the mouth. Like I said, children with Down syndrome may also have a larger tongue or a smaller oral cavity. When the tongue has insufficient room to move, chewing may not get completed sufficiently. This can lead to choking or even pocketing of food. The structural differences also may lead to increased oral food loss, as the tongue may protrude during swallowing and push the food out. Next is abnormal tongue movements. Again, this likely is resulting from the low tone. The jaw, cheeks, and lips typically provide stability to the tongue. You may notice that your child maintains an immature in and out movement of the tongue rather than an up and down movement. Again, this may result in swallowing difficulties and difficulty in progressing with textures. Low energy and muscle weakness results in poor trunk stability. Just as the jaw is the stabilizer for the mouth, the trunk is the base of support for the entire body, including the jaw. Hypotonia, or that low tone throughout the body, can decrease overall strength and endurance, and this is going to result in poor oral control. Again, the complications may be difficulty with chewing, swallowing, and even possible choking at times. Having a sensory system that is under-responsive indicates that the child is not aware of the sensory stimuli that is being presented to him. This results in missing information. For example, a child with Down syndrome may lose interest or take more breaks during feeding. They may forget that the food is in the mouth because they are not aware of it. It doesn't have a strong enough sensory input. Unfortunately, again, this can lead to swallowing too late, swallowing too quickly, and possibly choking. So what can we do? We'll go over these 5 evidence-based approaches, each in detail, in just a moment. So we know that we can improve muscle tone, which seems to be the strongest underlying factor. We can support their postural stability because we know that postural stability promotes distal mobility. We can support oral stability in the jaw, promote sensory awareness in the child so that they're ready to participate in the act of eating. We can look at the progression of textures so that we are progressing them appropriately and not providing them with textures that they're not yet able to manipulate. And if needed, we can also incorporate behavioral interventions so that we can extinguish some of those non-preferred feeding behaviors and again promote them to participate. As I said, infants and children with low tone may need to be helped to use the muscle strength and control that they have. To help encourage muscle tone, you need to wake them up or alert them before and during each feeding. Here are a few wake-up strategies. But be sure to review any of these that you would like to try with your family, with your developmental team or your physician. So we know that vestibular input increases muscle tone. So vestibular input is movement against gravity. Dance with your baby but make sure that the head and their upper body are in control and stimulated. You can bounce the baby gently on your lap, or you can swing the child in your arms. These will also alert the child system. We know that alerting the tactile system, which is on our skin and inside our mouths, the tactile system also increases awareness. So some parents have found that a cool or a tepid bath can help their child participate in eating. Others have found that a brisk towel rub or kissing the baby around the face and around the neck can also help increase their arousal. Waking up your child's whole body is important because the body is the base of support for the mouth area. Once the body is awake, it lends some strength and control to the mouth, which we will talk about in just a moment. Again, we know that proximal stability promotes distal mobility. When sitting at a table, the children need a stable chair, they need foot support, and they need trunk support. If your child isn't able to maintain an upright midline position, they may need postural supports to help them sit upright at the midline. Babies with muscles that are too floppy or too tight can be held in ways that allow them to suck better. Holding babies in the proper position not only helps them relax and better control their shoulders, trunks, and hips, but also helps them control their jaw, the cheek, the lips, and the tongue. This promotes overall smoothness of swallowing. Proper positioning can affect the baby's strength, organization, and energy for sucking, increasing the time that your baby efficiently sucks on the nipple. The baby's head should be supported in a chin-tucked position unless there is a medical reasoning prohibiting this. The head should never be tipped back. It always needs to be in a chin tuck. Nor should it be so far that the chin rests on the chest. The in-between chin tuck sets up the neck and the jaw muscles for the strongest sucking. Here are, when sitting at a table, as you can see, the child sitting at the table has, right here, he has adequate foot support, and his ankles, knees, and hips are all at 90 degrees. If your child is not able to sit this way independently, you may consider using an adapted chair like the ones pictured below. These seats provide foot support as well as anterior, posterior, and lateral support to maintain the child in a stable, upright position. Ideally, when looking at how the mother is holding the baby, the arms should be forward with the hands resting near or on the bottle. The position in which the baby's shoulders are drawn back in a tight or restricted position can lead to tension in the neck, jaw, and throat. Swallowing is more difficult that way. When trying to improve your baby's shoulder and arm position, remember that some babies cannot handle both arms forward yet. They may need to start with one and over time progress to both arms. Gradually, your baby may comfortably rest both hands on the bottle and may even hold your hands while holding the bottle. So we talked about improving muscle tone in the body through dancing and through swinging, but now we need to improve the muscle tone in the face. These muscles may need to be woken up before the presentation of food as well. You can wipe the child's face with a cool washcloth or tap their cheeks and lips with your fingers. This alerting continues to wake up the mouth as a good preparation for eating. The Nook massage brush, which is the first one that is on your slide, is a soft, bumpy rubber brush about the size of a toothbrush. It provides an alerting wake-up stimulation to the cheeks, the tongue, and the lips. You may also present the first few bites of strained food on the Nook brush. The Z-Vibe, which is the second picture on your slide, is a similar tool that incorporates vibration as an alerting tool. Vibration can not only awaken the oral musculature, but it can also decrease sensitivity to taste and texture if your child experiences that issue as well. Again, irregular movement, dancing, and bouncing can increase tone throughout the body, setting the child up for a successful feeding session. So we've discussed facilitation of muscle tone in the body and in the face. As we move higher throughout our hierarchy, we now must address the muscles of the mouth to prepare the child to eat. Using a toothette or a Nook brush, roll the tool on the sides of the tongue toward the cheek. Roll the brush firmly on the side of the tongue in a clockwise direction on the left and in a counterclockwise direction on the right, rotating toward the tongue's midline. It's easy to forget that children need to practice biting as well. They need to bite through a variety of foods with different textures. This helps refine that jaw control, which we know is an essential component of eating. You can use a chewy tube, which is pictured on your slide. You can also use your own finger, a strip of a carrot, a jicama stick, or even a biter biscuit that the child cannot bite through. Place the tube or the food on the molar area laterally and press down gently. Wait for the child to munch at least 10 times and then repeat on the other side. This is not time to eat the item, but to practice chewing. As soon as they are able, children with Down syndrome need to be given crackers, fruits, vegetables to munch on and to bite through. As always, only give food that your child can handle safely, and we'll talk about that progression in just a minute. Cooling the child's food or drink can also increase his and her awareness of the food, which will improve their reaction and facilitate oral manipulation. Begin with room temperature foods and gradually try colder and/or spicier foods that are more stimulating and may also increase the child's interest and tongue activity. Here's our hierarchy. The jaw provides the stability of the lips and the tongue. The jaw should act as the foundation of the mouth to promote mobility of the lips, cheeks, and the tongue. When we talked about increasing jaw stability through munching on a chewy tube, a carrot, or a jicama stick, you can use that activity through biting to also help stabilizing the jaw. You may need to provide stability using your hands under the child's mandible, which is right here, during chewing and swallowing to allow his or her lips and tongue to work independently. Many of the activities we have already identified will increase your child's overall sensory awareness and preparedness to eat. In review, dancing, bouncing, and swinging will stimulate the vestibular system and alert the child. Tactile input such as a cool washcloth on the skin, tickling, or kissing will also increase the child's awareness. Decreasing the temperature of the food and increasing the taste will alert the child's oral tactile senses and increase attention to manipulate the food. A child must first be able to organize and eat purees, meltables, soft cubes, and soft mechanicals separately before introducing mixed texture foods. The modification of oral pressure, tongue movement, and jaw stability for different textures requires refinement. When there are different textures, the child must stabilize certain textures in order to manipulate others. The same response cannot be used repeatedly as it can when eating a single textured food. A few examples of purees. You can puree regular table food to the consistency of strained foods by using a household blender. Progress to thickened puree when the child displays predominant sucking on the spoon during feeding. The child may not yet be able to move the food to the sides of the mouth using the tongue, but they are ready for thickened purees when they're able to suck the food off the spoon. A few nutritious thickeners that you can use include potato flakes, wheat germ, breadcrumbs, and dry baby cereal. Thicker pureed foods may also be produced just by using less blender action, including other nutritious foods such as oatmeal, cream of wheat, mashed potatoes, mashed banana, applesauce, or yogurt are good ideas as well. Next, you can move to meltable hard solids, such as graham crackers, veggie sticks, Gerber puffs, cheese puffs, baby cookies, Gerber, any freeze-dried fruits or vegetables. These are items that are going to melt on the tongue when they interact with the wetness of the mouth. Next are soft cubes. These are finger foods that have soft outside, and they do not provide great texture awareness to transfer the control of the food on the lateral surface for chewing. A dissolvable solid can be added to these foods if needed to add texture and sensory feedback. A few ideas of soft foods are avocado chunks, pieces of banana, softened peaches, anything that is going to mash easily. Soft mechanicals are foods that break up in the mouth easily. Fruit breads, pasta, soft meat soups with the broth taken out, scrambled eggs, mashed beans, mashed potatoes. We can then move to mixed textured soft mechanical. You want the difference between the liquid and the mechanical food to be minimal. So start with things like macaroni and cheese, spaghetti, thin lunch meats, things that the child is able to munch on quite easily. You can then move to soft table foods. Again, watching your child and making sure that the tongue is able to move the food from the sides of the mouth into the molars for munching, and the child is also able to sweep that food off onto the tongue and move it back for a swallow. A hard mechanical food is going to be the last type of food that you present to your child. This includes cookies, crunchy bread, pretzels, raw fruit and vegetables, and meat. These are foods that require a lot of strength and endurance to chew and munch to the appropriate texture for swallowing. It is recommended that a combination of oral motor and behavioral interventions may be used with children with severe feeding problems to increase intake. If you have a young child who is just having some difficulty feeding, you don't need to use many behavioral interventions other than the positive reinforcement. However, if your child is older, into toddler or childhood, and we've started to see some escape behaviors that are paired with the difficulty with feeding, you may want to consider using a behavioral intervention as well. Differential attention is when you pair positive reinforcement of the desired behavior with ignoring the undesired behavior. The positive reinforcement is going to be clapping, cheering, giving a body rub, a high five, anything that's going to encourage your child to repeat that behavior again. Escape extinction or escape prevention is when we're going to use non-removal of the spoon or not allow the child to use behaviors to remove the stimuli or the demand that is being placed on them. We may use ignoring, or we may use not being allowed to leave the table until that child in some way interacts with that food. Research has shown that this needs to be paired with that positive reinforcement or the differential attention so that the child knows what skills they do need to perform and not just what they don't. The stimulus fading is when you start with a very small amount of the non-preferred food and a large amount of the preferred food. This can be bite-sized, or this can be in regards to taste. You may fade the texture of the food and blend preferred or novel foods. That's another way that you can use stimulus fading. As the child accommodates to the taste or to the size or to the texture of the food, you can increase the amount of non-preferred as it may now be accepted, and decrease the amount of the overly preferred food. Simultaneous presentation is also known as pairing with the preferred food. Research has actually showed a faster increase in food acceptance than doing the delayed reinforcement. So this is where, if you want your child to try a cheese quesadilla, but they only really like having nachos, we're going to give them together, or maybe the nachos are part of the cheese quesadilla, and the child will be more willing to accept that. Differential reinforcement of alternative behavior. This is when you give a lot of reinforcement for a positive behavior prior to or in preparation of a non-preferred behavior. So this is when your child maybe is about to throw the food at you or about to throw it on the floor, and you catch them and you say, "That was a really good job, trying the pears, good job, buddy." And so we're giving them positive reinforcement for a positive preferred behavior, but we're also blocking that non-preferred behavior that they may have been using to try to escape. One other type of research that was shown is the flipped spoon method. This is using a flipped spoon presentation. This is going to result in decreased expulsions or spitting out of the food or packing, and increased intake. Again, these are for those children who have learned that spitting the food out or sticking their tongue out or refusing the food is an appropriate way to escape the task, rather than dealing with those underlying oral motor and sensory motor issues. So what does the research say? So food refusal may be misinterpreted by parents and physicians as a behavioral issue. However, when we look at the case histories, we see that there has been developmental, sensory, and biological systems all interacting that has made the task of eating for this child difficult. You may see gagging, choking, vomiting, or incidents with the introduction of purees or solid foods, in addition to possible medical and developmental issues. So food refusals can actually develop secondary to these medical and developmental or sensory concerns. Assessment and treatment of those underlying oral motor and sensory motor issues should precede any behavioral intervention. Using oral motor and sensory-based approaches prior to behavior, because that is the likely underlying cause. Research also shows that children with Down syndrome have atypical sensory processing patterns. They tend to demonstrate muscle weakness and low energy in response to sensory stimuli. This makes motor planning movements difficult. When this is compounded with the low tone, it is much more difficult for a child to achieve skilled movement. This is significant for gross, fine, and oral motor. As I said, when looking at a systematic review of all the evidence, it is recommended that a combination of oral motor and behavioral interventions be used with children with severe eating problems to increase intake. Like we just reviewed, the differential attention, positive reinforcement, escape extinction and escape prevention, stimulus fading, simultaneous presentation, differential reinforcement of alternative behavior, and the flipped spoon are all options. We have discussed the topic of oral motor control and sensory processing, specifically how these issues impact feeding, eating, and swallowing. We broke down identification of the underlying mechanisms using a systems approach to discuss the medical, developmental, and sensory issues that contribute to problems with feeding, eating, and swallowing. We have also reviewed literature that supports effective interventions to support feeding, eating, and swallowing, specifically the use of oral motor, sensory, and behavioral approaches. It is important to remember that our children are precious, and just because they may use a different approach to reaching their goals, they are still perfect.